Heinz has a question for you. Heinz, go ahead and unmute.
Hey, Doc.
Hey, Heinz.
I go through the forum quite frequently. There was an interesting question posed 3 days ago. Kim gave a really good answer, but I have a question related to that. And I'll read the question. How do your arteries get reclogged if your cholesterol is always normal? Where is the cholesterol that clogs your arteries coming from? And Kim kind of said, in a nutshell, it's an advanced lipid panel that shows you why. Something to do with not the fluffy type of LDL, but small dense. So what can you do about getting rid of small dense LDL?
So this is actually a very good question. So let me answer the first part of the question. Okay. So there are so think about, so you have a highway, okay, and you have a highway where there is a construction going on, all right, and you have a lot of concrete sitting there, and then you just have, instead of a 4-lane highway, you have now a two-lane highway. So it's the same amount of traffic is going through that, right? So similar thing is happening in the blood vessels. So when you have calcified plaque, that there is remodeling going on in the blood vessels. So you have a lot of this concrete build up, and there is same amount of blood trying to go through that narrow hose. So what happens is that when you are doing a lot of activity, when the flow is trying to increase, that narrowing cannot handle that, okay? So people will have angina, people will have claudication because there is a narrowing in the direct blood flow, okay? That's where the angioplasty, the intervention, and all that comes into play. Now, once you have intervened, there is a lot of inflammation which happens post-intervention. There is a lot of remodeling which is going on post-intervention. So sometimes because of that excessive inflammatory response, you can develop narrowing in the area which is already treated, whether it is the instant restenosis, so neointimal hyperplasia, multiple different terms, right? So that's one mechanism. The other mechanism is that you have treated the concrete, but then there are other areas where you may have a little soft plaque, right? Or a traffic cone, and you're driving at the night, you didn't really see the cone, and you hit the cone, and boom, you have a car accident, right? So same thing is with soft plaque. So the soft plaque, the blood is coming in with turbulent flow, and it can sort of damage that soft plaque and cause a micro hemorrhage or micro trauma in that area. So that plaque can rupture, and then the body thinks that, oh, I'm bleeding somewhere, I got to plug that hole. That's when the acute clotting happens in the arteries, called the thrombosis. So that's the mechanism of acute heart attacks, right? Or acute limb ischemia. Then we know sudden development of a blood clot. That's an emergency. So that's where you have to treat, with multiple modalities. So those are, there are multiple different mechanisms why you can have reocclusions, whether it is in the original area or a different area, okay? So then the question becomes how we treat it. So right now, the only available modality is to work on the LDL. So we have your statins, we have the PCSK9 inhibitors, we have the insulin inhibitor, the Leqvio, which is excellent. And now we have a newer drug called the bempedoic acid derivative, which is nexletol. So we have 4 or 5 different medications to treat the LDL part of it. But there is data to show that the LPA2, lipoprotein A2 activity, or apolipoprotein B, if they are elevated, they increases the risk of having a cardiovascular event. But right now, we don't have any drugs for those molecules. I think within the next 3 years, we will have at least 3 different drugs targeting the LPA2. So clinical trials are actually currently going on right now. And then there are also trials going on to look at the triglycerides, which are the fluffy fatty particles. So we have 2 or 3 good drugs right now to treat that, but there are more monoclonal antibody-based medications which are now under clinical studies. So I think in next 3 or 4 years, the whole treatment paradigm of cholesterol management is going to change very, very dramatically.
Wow.
So, yeah.
Right. So basically, if it's not just about the cholesterol, then the cholesterol is just a piece of it. And having normal cholesterol doesn't mean that you're not going to reocclude, and doesn't mean that you shouldn't be,
Because
on a statin.
so the LPA2, that's genetic. So we're talking about familial hypercholesterolemia. So there are different types. So again, there is no treatment available, right? So I will do the advanced lipid panel in somebody who has higher risk, to kind of sort of risk stratify them, especially in younger patients or patients who have early onset disease or strong family history. And that just tells me how aggressive I need to be in lipid control, if they're diabetic, blood pressure and what have you, diet. But I can't modify their LPA2. I can't modify their LDL pattern type. So there is LDL pattern A, there is LDL pattern B. The pattern B is the one which is more sort of risky, but there is no way for me to modify that. So even if I have that information, unfortunately, right now, as of today, there's not much I can do except lower the LDL.
Yep, that's actually, so as you know, my dad, so when he was at risk, for a heart attack, and he was having some symptoms, the doctor brushed him off as having just indigestion. And I said, well, I think we need to do an ECG. And she said, no, his cholesterol is normal. And I had to educate her that more than 40% of people who, had a heart attack, I think it was 40%, have normal cholesterol in a basic lipid panel. And for my dad, it wasn't until we did the advanced lipid panel that we found out, one, he was pattern B, and number 2, he had a very high LPPLA2. And then number 3 is he had a very large number of the small dense LDL particles, a very large number. It was really off balance with the larger fluffy LDL particles. And the doctor was like, yeah, we need to do actually more. They sent him to Boston Heart Diagnostics and found out that he didn't really have a liver production problem for him, but he still needed to excrete some of that out. So he had a cholesterol reabsorption issue. And so he had to increase the soluble fiber, and that seemed to bring it down significantly. So, but each person is so different. And it's good that you ask these questions, and that I really appreciate you taking time to explain all the different aspects, not just with the cholesterol and how it could damage or cause a problem or reocclude, but also when it comes to some of the other mechanisms of action. So that was really important. Heinz, did that answer your question?
Yes, it did. Thanks, Doc.
You're welcome, Heinz.